My disclosures. Okay, so stent. This is on stent options for veins, and you can see the laundry list of stents there. And obviously, in the middle, we have the new venous stents from the 4 companies, 2 of which have already received FDA approval. So here, just sometimes we use these stents, G and Turco Z stents, and they can be very helpful. They come in a variety of sizes and all 5 centimeter in length, basically ranging from 15 to 35 millimeters in diameter. And they can be actually useful in IVC and also very, people like the case Rob showed, if you didn't have these venous stents, for those flattened nitinol stents, they could actually be very helpful. Here's a case for the IVC, you can see there. And then nice 2 Z stents there taking care of the problem. So now let's go to the self-expanding stents. We've already heard mention about the wall stents that are probably the most popular used, and then the other self-expanding laser nitinol cut tube stents, smart stents, protege stents. And you can see there down at the bottom, those are the years that these stents came out. And so these are the stents we had for most applications for venous disease. The wall stent, I think we've already gone into this. It's self-expanded based on its braided design, but it is a closed cell stent. And here, is a nice case of a wall stent. We've already seen this. It is probably the most studied stent in the venous system because it's been used for a greater part of 20 years. You've already heard mentioned that it has really nice radial resistive force, but that is when the ends are on the vein, not centrally, okay? So that's why you want to have a well-positioned stent, which can be challenging. And for a long time, it's the only stent self-expanding stent until recently that came greater than 16 millimeters, and it actually goes up to 24 millimeters. Accurate deployment, you've seen this picture, can be a challenge, but here it can be very useful, especially in this case of reconstruction. Cons for this stent, as I said, accurate deployment can be a challenge. You've already heard now in a couple talks potential caging of the contralateral iliac vein. Here's stent already referred to. You can see contralateral DVT. Honestly, in practice, this is really very uncommon. And having even contralateral narrowing, as we saw in Rob's case, that causes a clinical problem, really uncommon. But here is such a case. And then last, a wall stent doesn't really conform to the vessel as nicely, and so sometimes stent apposition on the vein wall can be an issue. So now we have these nitinol stents, the proteges and the smart stents, which were really made for arterial use, but because of sizing, has gotten a lot of use in veins. You can deploy them very accurately. They don't foreshorten as much as the wall stents, and they can really nicely conform to the vessels. They have only been available in 14 millimeters and below, and there's definitely a smaller body of literature. And this is sort of the quintessential picture of the nitinol arterial stent in the venous system. Yes, they go in, but you're having this tremendous flattening of the stent, and a lot of that has to do with the stent construction. You have both open and closed cell design, but you can see here this stent is made to be flattened at those choke points. Okay, and here 2 different nitinol stents, and that's exactly what happens in those stents. Mahmoud, who's sitting here, had a nice meta-analysis that he published where there was excellent, in 30 plus studies, excellent technical success in all different disease states. So this looked at the non-thrombotic iliac vein lesion, it looked at acute DVT lesions and chronic DVT patients. With significant pain relief. Of course, the chronic thrombotic patients are a much more difficult group to treat. And then, really excellent primary patency rate, and it goes down when you're dealing with more chronic DVT. And then secondary patency is, in a lot of these studies, is going to be high in the high 80s and 90%. So now we have these new dedicated venous stents, the Vici stent and the Venovo stent. You've already seen a couple of those cases. You saw one used this morning. Those have already completed trial. They have gotten FDA approval, Venovo first, and most recently Vici. And they were based on trials, okay? And here are the trials. And, the other trials are going to be coming out very soon. with the Medtronic stent and the Quicksilver venous stent. And you can see the number of patients they had there. The VENOUS stent, again, an open cell design, really nice because as you saw in that case, they go up to 160 millimeters in length, which is really nice for using one stent. And again, I focus a lot on cost because cost is important, whether you're doing this in the hospital or in an outpatient facility, and using one stent as opposed to stacking what you happen to have on your shelf. And then look at that, we just used 3 stents, so that's less than ideal. And here, excellent primary patency with that VENOUS stent, both actually in the PTS patients and in the non-thrombotic patients. Safety, almost 94% freedom from any kind of safety event at 30 days, low incidence of PE and procedure-related complications. Okay, the Vici stent. Now the difference of here, this is a closed cell stent. You have the 12, 14, and 16 millimeter diameter stents, 60, 90, and 120 millimeters in length. And the interesting thing for this is this stent trial did not have the acute DVT patient population and actually had more chronic thrombotic and advanced venous disease patients. And here, the primary patency rates, again, exceeded its performance goal. You saw it at 84%. And for the non-thrombotic lesion, as we would expect, similar to the VENOUS stent, very high primary patency rate at a year. And again, the post-thrombotic patients, about 80% primary patency with a very low complication rate. Okay, and obviously in all these trials, you do the procedure and you're going to see improvement in these VCSS scores. And then, so let's compare them side by side. Okay, the percent of PTS patients was definitely higher in the Boston Scientific Vici stent population, something that they promote. Okay, so this is going to be that patient population they're trying to get. And then both very similar, primary patency rate in those patients and also in the non-thrombotic lesions as well. We're looking forward to the Silver stent. Again, this is a dedicated Silver venous stent, and then the Medtronic Arbor stent as well. There are stents available outside the US. I think you saw this in Angela's talk, which, they're really much more evolved in venous stenting than we are in the United States. This is a nice sinus obliqua stent where you could really hit that and keep this truly a unilateral reconstruction as opposed to caging and going well into the vena cava. You've already seen the slide, so I don't want to spend too much more time on it. So in conclusion, these venous stent trials are for dedicated venous stents. I think, it's not like we're going to just abandon the wall stent. I think the wall stent, as pointed out, has a lot of great crush resistance. So it's really going to depend on the pathology. And, these trials show us data at 1 year, but we're going to have to really see where these stents fit in our venous practice, as opposed to just saying, let's forget the wall stent. Because again, the wall stent has what it has is a long track record. And so that is my talk. Thank you.